Do you know what neuro-ophthalmology is? Today we're going to start a series of interviews with Dr. Larry Brenner by discussing what neuro-ophthalmology is and why it's so important. There's also a story about cat scratch fever, if you're into that sort of thing. Make sure to tune back in next week for the next interview discussing the evolution of ophthalmology over the past 50 years. Dr. Brenner?
I want to talk to you.
Not now, later.
No, now.
All right, today our guest is going to be Dr. Larry Brenner. And in addition to being the Director of Neuro-Ophthalmology Emeritus with the University of Texas, he also happens to be one of my favorite people. Dr. Brenner, thank you for being with us.
Pleasure, Thomas. Nice to be here.
Well, Dr. Brenner, obviously I know a lot about your history, but could you share a little bit about your history with the channel?
Oh, sure. I'm by training a general ophthalmologist of some 30 years, after which I was recruited by the University of Texas to take over the position of Director of Neuro-Ophthalmology. And I did that after some trepidation since I had not done a fellowship, but I sort of learned on the fly, and over the next 14 years I headed that division, trained residents, saw many patients, interacted with many physicians and neurologists and other specialties, and learned to have a great appreciation for neuro-ophthalmology.
This is something, I remember the first time that you and I met, you had to take some time to explain neuro-ophthalmology to me, because at the time it was something I had never heard about. Can you take a moment to explain what is neuro-ophthalmology?
I think the best way to explain it is to tell you and to tell those who are watching what it is not. A general ophthalmologist basically treats most of the conditions of the eye that people are aware of, all the way from glasses and contact lenses to cataracts, glaucoma, retinal disease, retinal detachments, a whole range of pediatric problems. And those are the things that we faced in general ophthalmology and saw every day. What neuro-ophthalmology is first of all, most of the things that happen in neuro-ophthalmology are more serious, more complex, and play a part more of the general medical concept on what happens to your vision, your ocular motility, and your ocular well-being. The diseases that we treat often require extensive, usually non-surgical treatment, high-range pharmaceuticals, significant diagnostic studies and tests, and required a great deal of patience and time, both in evaluating the patient and treating the patient.
So tell me about a typical patient. So obviously we're talking about that some of the disorders that you're treating are not things that would typically be treated by an ophthalmologist. So what are some of those disorders? What are some things that you might see as a neuro-ophthalmologist?
I think the commonest ones we see are diseases of the optic nerve. And I think they occur in so many different ways that the average general ophthalmologist sees so few of them in a given year that it's very difficult for them to discern them as well as to factor them out as to where they belong. For example, inflammatory disease of the optic nerve, optic neuritis, has about 10 different kinds, all the way from that due to high blood pressure to the complex aspects of multiple sclerosis, to the complex aspects of a condition called pseudotumor cerebri, in which the brain produces too much spinal fluid and it gets high pressure inside the brain, which is transmitted to the optic nerves and they become quite swollen. Tumors of the optic nerve, optic nerves that are congenitally abnormal or have for some reason become atrophic, that is non-functioning without reason. The whole range of optic neuritis and inflammatory diseases in itself is almost a subspecialty. But it is, I think, the single commonest serious thing that I saw, but it was just one of many.
So maybe we could take a minute to talk about if we're dealing with most of the problems that you deal with are with the optic nerve. Could you take a minute to describe what is the optic nerve?
The optic nerve is the structure upon which, in the back of the eye, all of the nerve fibers that begin in the front of the eye and go to the retina are then excited by neurons and form ganglion cells and axons. Those are little arms that leave from cells, and those axons coalesce in the back of the eye and form the optic nerve. The optic nerve has something like 1 million optic nerve fibers in the optic nerve, and it is only 1 millimeter to 2 millimeters in diameter. It is basically an extension of the brain, for all the visual fibers that enter it go into the brain to the posterior part of the brain where our vision really is recognized by the patient. So we think we see with our eyes, but we really see with our brain.
So in a lot of ways, the optic nerve is the interface between the physical eye and the brain itself.
Exactly.
Very good. So when you're looking at these sort of things, we talk about diagnostic tests. I would imagine that the tests that you're running may be a little bit different than what you find in the normal ophthalmologist office. So how does that differ, and how are you diagnosing these disorders in the first place?
The patient has symptoms, usually of visual loss of some degree, either acutely or subacutely or chronically over a period of time. In some cases, they may not even have much vision loss, and it's referred by an ophthalmologist who notices physical changes in the optic nerve. The diagnosis is made, first of all, by checking the patient's vision. But then we get into other things that again are not done on every patient in a general ophthalmology way. We do color vision testing. We do intensive visual fields, that is the extent of their vision, not just the clarity, but the extent of their vision off to the side and around the center. We do tests in which we are examining the optic nerve in great detail with something called OCT, which is a form of tracing of the optic nerve. Sort of like a mini MRI of the optic nerve. And then, of course, we also can do visualization of the brain and the optic nerve, both by CAT scan and MRI, and in some unusual cases by PET scans. So we can see how the patient's seeing, we can test the extent of his visual field, and then we can see if we can identify a problem. Sometimes the problem we identify is the major problem, not just with the optic nerve, but the major problem causing the optic nerve. For instance, the patient may have optic neuritis. We do an MRI and we see typical findings of multiple sclerosis. And patients will present with vision loss as an initial symptom of multiple sclerosis in 25 to 40% of cases.
That is very interesting, and I was unaware of that. But even what you're describing here, we're talking about PET scans, MRIs. These are definitely not things that you would typically find in an ophthalmologist, an ophthalmologist performing these sort of things.
Nope, they aren't, and that's really what makes this field so intense, and so it was really so much enjoyable to me because I really had a chance to do what I thought I was best at, and that was practicing medicine and practicing how diseases play upon your vision and your eye and your motility. The rest of it, the general ophthalmology, I enjoyed for 30 years, but I really found it after a while to be rather repetitious. I was a surgeon, did a lot of surgery, but it was sort of repetitious. It didn't require a lot of thinking. It required a lot of doing. Neuro-Ophthalmology requires a lot of thinking.
Right. Well, so I've heard you tell this story before, but I think it's somewhat of an interesting one about how did you make that transition from being a general ophthalmologist into neuro-ophthalmology, and how has your career progressed along that path?
As we approach the 30th year in general ophthalmology, I decided it was time to quit because I was going to die very soon. And I say that not exactly with tongue in cheek, because everybody in my family died young. My parents died before they were 50. All three of my brothers died before they were 60. And here I was right around 60 and thinking, well, I guess I have 2 or 3 years to live. I think I'll just retire from ophthalmology and go out to Sugar Land and play golf. And so that plan occurred, and I was about to do it when a friend of mine who was the head of the University of Texas Eye Clinic asked me if I was really going to retire at this age. And I said, well, yeah. And I told him why. And he said, well, I don't think you should. I think you should come over and be the director of neuro-ophthalmology. And I said, do you need one? He says, yes. The one that we've had here for 7 years is retiring and moving back to Vermont or Rhode Island or someplace. And I said, I don't think I'm qualified to do this. And he said, yes, you are. And we bantered back and forth for about a month and negotiated this. And finally, I decided to go to Orlando, where they had the American Academy of Ophthalmology meeting. And I saw this head of ophthalmology again coming down an escalator. And I was going up the escalator, and he started negotiating with me again on the escalators as they were crossing. And of course, this was very amusing to all the other ophthalmologists and the attending people who were getting a big laugh out of all this. Anyway, we went to dinner that night. He convinced me I should try it. I decided to try it for 6 months, and the 6 months lasted full-time 14 years and part-time for 6 more.
Well, walk me through a little bit about, when you talk about that there's a lot of thinking, a lot of research that's going on. So walk me through a little bit about, first of all, how are you getting patients? And then what's the process like to get to diagnosis?
Patients are referred, I really can only guess, but I would think that about 75% of the patients I see are referred by other ophthalmologists, primarily general ophthalmologists who see a patient in the office and basically need some help with diagnosis and treatment. The rest of the patients are sort of broken up between neurologists, a few general practitioners, and just walk-in patients who know something's wrong, doesn't seem to be what's wrong, or they went to an optometrist or another eye care physician and was not happy with the diagnosis. One of the patients that comes to mind most is a patient who walked in after being referred by their best friend because they had profound vision loss and had been at another medical center and had been worked up for 4 days in the hospital with every test they could think of and could not come up with the answer. And she was brought to me, and it turned out that she had cat scratch fever, very interesting disease brought on by an organism transmitted by the scratch of a cat. They get it through fleas, and it causes an optic neuropathy, which is somewhat typical in its appearance. I was lucky and able to see that, and I'll never forget, I asked the patient, when I saw him, I said right off, how many cats do you have? And she looked at me like I was crazy. She says, how do you know that? I said, why, how many do you have? She says, 3. So anyway, we were able to treat the patient and recover most of her vision. And it ended up on a national television program called Monsters Within Me, and they had me on and we talked about this disease. It's a fascinating disease.
Well, so talk a little bit about that. So we talked that you're not doing eye surgeries per se, right? So when people are coming in with these different disorders, what does the treatment look like? But for instance, the one that you were talking about, what does that treatment look like?
Well, most of it's medical. It requires a wide range of treatments, all the way from steroids to antimetabolites to monoclonal treatment, to antibiotics, to anti-inflammatories, those are the key things. And then some of the medications that we use have considerable side effects. I mean, I was in general practice of ophthalmology, I never used anything that was a autoimmune suppressive thing that's used in multiple sclerosis or in giant cell arteritis, things that require a great deal of follow-up, laboratory follow-up, careful monitoring of side effects, which can be considerable. They're just dangerous drugs. And because of that, it requires a lot more research and constant review to apply these medications properly.